Hello, everybody, and welcome to Oncology for the Inquisitive Mind, the podcast that aims to illuminate, demystify, and deconfuse the wonderful and rapidly evolving world of oncology. My name is Michael Fernando, and I'm joined by my illustrious co-host and very good friend, Dr. Joshua Hurwitz. How are you going, Josh?
Not too bad, Mikey. How are you?
Not too bad, not too bad. So, both of us are a few years into our oncology training, and I guess this being our very first episode, we'd talk about what led us to actually come up with this idea. Because I think, Josh, I would be fair in saying people don't want to be an oncologist from childhood. It's not one of those things. So when you decide you want to do it and you start your training, it can all be a bit overwhelming. Do you agree with that?
Yeah, no, look, that's really true. And to be honest with you, what you see when you see your bosses or you see your superiors do oncology versus the day-to-day ins and outs are very different. When you start med school, oncology generally isn't the top unless you sort of want to do that research side. But yeah, it's a whole different ball game when you're doing it all the time.
Yeah, especially in those first few months where you've been asking other people for advice, and then all of a sudden they're coming to you asking for diagnoses and prognoses. It can all be a bit overwhelming. So what we thought we'd do, this podcast aims to or is aimed at, I should say, a wide variety of people, even people who are non-medical and just interested. But the main audience we want to reach are those people who are about to start and have absolutely no idea where to start learning, just to ease you in it. So what we'll be doing throughout this podcast is with a eclectic cast of characters joining us along the way, going through many of the basic and seminal trials, and hopefully providing some interesting discussion.
And maybe even some clarity on rationale as to why we do things. And if we can break it down and make it simple, that's, I guess, really our goal, because that's what I would have wanted when I started, or even like when I was doing my junior training, like being like, I don't understand this. So we're hopefully going to break things down and just make it enjoyable and a little bit easy to understand.
Yeah, and hopefully we don't send too many of you to sleep with our dulcet tones.
That's my job.
So today we figured we'd start off simple because as any oncologist worth his salt will know, that there is a science to oncology and there's also an art. But one of the tumours that is both common but also has a little bit less in terms of grey is that of prostate cancer. So to start off, we thought we'd start there. I'll give a bit of a background, Josh, if I may, just a simple summary of prostate cancer.
Go to town. Love to hear it.
So I'm sure that many of our listeners and many oncologists and people in the general public will know someone who has had prostate cancer in the past. It is among the most common cancers worldwide. A number of years ago, it was estimated that there were over 1.5 million cases and over 350,000 deaths worldwide. So it's definitely something that is going to come up very commonly in any oncologist or oncology trainee's practice. The overall 5-year survival rate, though, is over 98%. So these are patients who tend to follow us around, or we tend to follow them, I should say, for quite a long time. And it's one of those cancers that we've gotten really, really good at treating, probably because it is so common. Prostate cancer is divided into two sort of segments, I guess you could say, with the dividing line being when androgen deprivation therapy, or ADT, stops working. ADT, is a little factoid, Josh, has been known as a therapeutic option since 1941.
Do you know who first founded or identified it, what his name was?
I do, once I get my thing up here and start cheating.
So since you brought up 1941, I thought I just had to ask.
No, here we go. Hang on. It was Charles Huggins, apparently.
Yeah, great name, must say. The only thing to add so far is that I think it was this week that they've actually said prostate cancer will be the most the highest diagnosed cancer in Australia. It's overtaken breast cancer. I'm pretty sure.
And that's probably a part, at least partially due to the fact that prostate cancer is predominantly a disease of old men. I know you've said this, Josh, in the past, that if every man was to live to a million years old, then every man would also get prostate cancer at some point.
Yeah, we can guarantee that on this podcast.
Yes. That's the podcast, Josh and Mike's guarantee. So, in terms of looking at prostate cancer, I guess the main players that are going to come up in this podcast are the idea of hormone-sensitive prostate cancer, which is when ADT or androgen deprivation therapy is actually working, and castration-resistant prostate cancer, which is when it tends to work less and further things have to be added on. And for this first episode, we're going to look at hormone-sensitive prostate cancer.
And just before you kind of head on it, like you mentioned something really interesting, Mikey. When we talk about castrate sensitive and castrate resistant, because I was doing a little bit of interesting reading about Charles Huggins before this podcast.
Just because he had the world's best name.
He does, and I wish I had a name like that. I'd go to see him as a doctor. But my question is this: castration, or like male castration. We see generally chemical castration, but have you seen much in your practice, like physical castration of, I guess, your patients?
No, I can't say that I have, although I have read, probably when I was going on a similar wiki walk to you, that was one of the first methods of androgen deprivation therapy was physical castration.
Interesting. Anyway, sorry, please.
No. So I guess the main players with this are that enable us to track when prostate cancer becomes castration resistant is the PSA, or prostate specific antigen, which is one of the more accurate tumor markers. Most tumor markers aren't worth the paper or the pixels they are written on, but PSA is one of the more useful ones, as well as imaging. Now, there's conventional imaging, which I'm sure Josh will mention in his charted analysis, which is CT, chest abdo-pelvises, and whole body bone scans, nuclear medicine bone scans. But I guess a point of discussion that we'll have when we talk about charted is how the introduction and wide adoption of PSMA PET, which is widely deemed to be more sensitive at picking up small deposits of disease, has potentially changed that. So without further ado, just to frame this whole conversation, I'll just provide a bit of a case. So you're a first-year oncology trainee. You're about a week into the job. If you're anything like I was, you're absolutely scared out of your britches. And you see a patient in clinic who's 68 years old and has been referred to you for consideration of systemic therapy for a new diagnosis of prostate cancer, never been treated before. And obviously, aside from the prostate and from some pelvic lymphadenopathy, he's also got more prostate cancer in his bones than bones. So he's got particularly affecting the spine, nothing critical, of course, but also lesions in his humerus and his femoral shafts. So I guess the question that will be plaguing this hypothetical trainee's mind is, what the hell do I do? And so let's talk about charted, Josh.
Yeah, so as a trainee, I'd definitely take that history and then speak to my boss. But
it's a good general rule.
Yeah, so look, charted's actually a bit of an older trial, which I didn't realize. I was like, it's obviously one of these things, but it's from 2015. And the title, so it's a Sweeney paper, but essentially the title is Chemohormonal Therapy in Metastatic Hormone-Sensitive Prostate Cancer. So breaking down the title, I know it's boring, it's like it's a title, but look, literally you're giving chemotherapy in addition to an androgen deprivation therapy in someone who's been diagnosed with metastatic cancer early stage. So what I mean by that is they haven't had multiple lines of therapy.
Because we don't generally see sort of localized prostate cancer, do we, Josh? It normally comes to us when they do have metastatic disease.
No, look, yeah, you're completely right. If it's localized, they're probably going to be managed by their urologist.
With maybe with the radiation oncology as well.
Exactly, because people don't refer generally to an oncologist if you've got trouble peeing, and if they do, then we'll probably refer on. Yeah. So look, I guess this was a good study for a number of reasons. So the background to this is that what they know, and they've known this, as Mikey said, for about 80 years. ADT is the backbone of treatment for metastatic prostate cancer. Their question was whether giving docetaxel, which is the chemotherapy agent, would actually make someone live longer than those with just ADT alone. Okay. Looking further at the background, this has been the mainstay of treatment. They had meta-analyses before this, and essentially, docetaxel was used in a later line of therapy, which did show benefit, but with a lot of effective treatments and not just docetaxel, they want to see what happens earlier on. So the other trial name for this, to let you guys know, is actually the E3805 study. I think they potentially changed the name later on because looking at the original publication for New England Journal of Medicine, they didn't really have it mentioned.
Maybe Chartered was just catchier.
Look, yeah. So one of the I guess the tidbits for practice changing publications in oncology is usually they have really great names. And you're like, oh, who comes up with this? And to be honest with you, I don't know. Maybe Michael can fill us in on this. So let's go back about what exactly they were doing. So the treatment plan. So patients were randomized to either receive ADT alone or in combination with ADT plus docetaxel. So I'm not going to go through the dosing because I don't think that's important here. But essentially, the treatment was given every 3 weeks for 6 cycles. And they're pre-medicated with dexamethasone. A lot of our patients are. It's very good for symptom management. When we're looking at how they were stratified, age, were they less than 70? Were they over 70? What was their performance status? So ECOG, looking at how active they were, either a 0, 1, or 2. So just for people who don't know about ECOG performance status, it goes from 0 to 5. 5, essentially, you're dead. And 0, you have no functional limitations at all. And so they don't generally use ECOG 3 to 4 in trials because these are quite brittle patients. And if you give a new treatment and you make them really sick, doesn't really help. Okay.
And they frequently have medical conditions that can confound the data, right, Josh?
Yeah, exactly. So you actually can't say whether or not the person was sick because of the treatment or because of something else. Okay. So other things to really talk about the stratification and sort of enrollment of the patients. Prior adjuvant ADT was allowed if they'd had treatment that was less than 24 months or less and had progressed and had occurred more than sort of 12 months after completion of therapy as well. So anything else to really talk about in this trial? So yes, one of the things that this trial did, and this is actually a really important component, is you need to know how extensive the metastases. So what they were asking in this trial is, was this high volume disease or low volume disease? And for a long time, I'm like, what does that mean? Like, you've got cancer. Like, high volume means you've got lots of cancer, essentially, to kind of break it down. Low volume disease might be just localized extension from the prostate bed. But, you've got some lymph nodes. It's considered that it has spread, but it's not in any of the viscera, other name being organs or any of the bones. And so they kind of stratify the extent of the metastases, high volume, which they defined as organs or greater than 4 bone lesions, with greater than 1 beyond the vertebral bodies and pelvis. Michael, do you know why they decide that as the kind of where they stratified the bone lesions?
I don't. I do know that obviously just based on people who have had prostate cancer that I've seen is that like prostate will make a beeline for the vertebrae. Was it because if you have disease outside of the axial skeleton, so humeral shafts, femoral shafts, skull, that you're potentially considered more advanced and therefore more likely to benefit from more intensive therapy? I don't know.
Look, that might have been their rationale, and it kind of does make sense. So we do find with patients that have more extensive disease, they generally have a bigger response when they're given treatment, purely because there's more cancer to attack, there's more genetic mutations, which means not all the time, but a lot of the time, these cancers become sensitive to these drugs.
But they do also sometimes need a bigger kick, don't they, as well? So you're going to have a you're going to need a bigger hammer, a bigger metaphorical hammer, as it were, to help these people survive as long than compared to the patient who has one or two bony lesions that are tiny.
Yeah, no, exactly. So talking a little bit more just about patient demographics, it's always important. Everyone was a man, just to put it out there. And generally in their 60s, like Mikey was saying, majority were white and everyone had a pretty good performance status. Things to actually focus on here is about 2/3 of patients in both cohorts had a high volume of disease, with quite a few, I think, having like bone metastases actually. And looking here, at least 20% had sort of a prostatectomy, which means they had their prostate removed. But a lot of patients, probably 3/4, hadn't had any prior local therapy. So I think these are predominantly people who were metastatic at time of diagnosis.
Because there's no point cutting or irradiating the prostate if it's already metastasized, correct?
Yeah, exactly. So it goes with prostate cancer, but also a lot of other cancers. You can chop out the primary tumor, but if you have tumor elsewhere, then you're not actually helping this person. You're not helping the person by taking out the prostate bed. It's just causing problems. So one of the cool things about this trial, it's a pretty long follow-up. They had patients that they recruited from 2006 to 2012. 790 patients were enrolled and essentially were randomized to either A or B. At the interim analysis, the total in October 2013, about half of the patient had their full information, and they kind of got an analysis, which was absolutely awesome here. So things to look at with survival, which was one of the questions. So guys, this is a great study. So one of the things we find is that actually having overall survival data in a lot of our trials is difficult. A, because of short follow-up time. B, because of potentially, it's not powered for that. But the study was. So median overall survival, as I was saying, 13.6 months longer when ADT was given with early docetaxel than versus ADT alone. So that was 57.6 months versus 44 months, with a hazard ratio for death of 0.61. Statistically significant with a p-value of less than 0.001. You'll find with a lot of our studies and our data, we're going to talk about if something is statistically significant or not. And the very basics of that is if it's not due to chance, it's going to be statistically significant, which means we can say with some certainty that this intervention is actually better than what we've previously been doing. Other things that they spoke about, 85 prostate cancer deaths in the combination group versus 114 in the ADT alone group. Now, what they did find is that with the analysis, those with high volume disease was better than the overall survival, where the median overall survival was 17 months longer in the combination group with ADT versus that alone, right? So what I spoke about first was all patients, but what we are really interested in here are those with high volume patients with a hazard ratio of 0.6 and a much longer overall survival as well. So that's great. And at this point, the median survival time, the analysis hadn't actually been in the subgroup with the low volume disease. And if we just duck across to an update before I continue on this trial, which really showed that after a median follow-up of almost 6 years, Mike, it was 53 months, 12, 24, 30, 48. Yeah, 5 years. That's embarrassing. I'm not going to be able to edit that out. But
Maths was never your strong suit.
I'm better at chemo dosing, I promise. So realistically, for those with the low volume disease, no overall survival benefit was observed with a hazard ratio of 1.04. And when you've got a hazard ratio above 1, what does that mean?
That means it's not statistically, or it's not any different, or it might be worse.
Yeah, so there's no perceived benefit of your hypothesis or your intervention arm, really. So secondary endpoints, like a lot of studies, they look at toxicities. This one was also looking at PSA. So Michael mentioned prostate-specific antigen before. We wanted to have a look at kind of, PSA changes, really. So the proportion of patients had a decrease in the PSA to essentially negligible at 12 months. Was 27.7% in the combination arm versus 16.8% in the ADT group alone. Median time of development to castrate-resistant prostate cancer, which essentially means they no longer respond to our hormone suppression techniques, right? was about 20 months in the combination arm and 11 months in the ADT arm.
Most common grade 3 to 5 adverse events were febrile neutropenia, hypertension, and fatigue. As a practical note, one of the things we always look at for enzalutamide, starting enzalutamide, is rapid LFT toxicity. So when you start a patient on enzalutamide, at least where I'm working at the moment, the common practice is to get them back with bloods at 2 and 4 weeks to make sure that their liver hasn't I don't know, spontaneously combusted. But that wasn't really a feature of the toxicity data in Enzamet. So as of 2019, we're looking at the addition of a drug that to the hormone-sensitive space that almost certainly has a statistically and clinically significant benefit, but there was probably a little bit of finessing to be done that could really only be done with ongoing follow-up. And fortunately, that update was recently presented at the American Society of Clinical Oncology meeting in sunny, I guess, Chicago. This was an ongoing analysis of the data that was at 68 months, which is 5.5 years, Josh?
Yep. I'll take your judgment.
Yep. So, more than 5.5 years, and it was basically looking at a greater body of data and taking a closer look at that data. So the main points from the update were looking at patients and seeing if there was a difference between patients who had synchronous and metachronous metastatic disease. And what that means is synchronous disease is patients who present with metastatic disease at the time of diagnosis, what we call de novo metastatic disease. Metachronous metastatic disease means that a period of time, I think in the study, they said sort of 3 to 6 months, has passed between diagnosis of prostate cancer and the onset of metastatic disease. There's also some evidence from our first friend of the show, Dr. Sweeney, who was involved in Chartered, I believe, who that patients with metachronous metastatic disease potentially represent more indolent disease, so they could potentially have better outcomes. There was also an exploratory subgroup analysis that looked at patients, again, with synchronous or metastatic disease, or patients with high volume or low volume disease. And it also tried to separate the benefit of docetaxel from the benefit of enzalutamide, trying to tear those particular threads apart. So in terms of the overall survival of the combined cohort, so this is every patient that ever received more than one dose of the trial drug. So at 5.5 years, median overall survival was 73 months, if you can believe it, in the control arm. And it still was not reached in the enzalutamide arm. So we're getting to 5.5 years, and less than half of the patients taking enzalutamide have had events.
That's just insane.
Yeah. It really is. And you know, there are very few spaces in medical oncology where you're going to have this sort of prolonged response in this proportion of patients with metastatic disease. Like we see it with adjuvant patients who have the cancer cut out and then chemo or what have you, and then they're cancer-free. You know, that's hopefully what we would expect. But for patients with metastatic disease who are just trundling along, to get to 5.5 years and still not reach the median overall survival is just astounding. The 5-year survival rate in the control arm was 57%. So even patients who are not getting enzalutamide are still doing really well. Over half of them are alive at 5 years. In enzalutamide, it was 67%. So again, you're theoretically overall doing better if you have enzalutamide in the hormone-sensitive space. I think the something else to mention, and this is something that I guess once you start digging deeper into studies in medical oncology, does sort of color your interpretation of how the data is presented, because what Professor Ian Davis, who's the first author on Enzamet, presented at ASCO was also data on therapy after progression. So patients, even when they progressed and came off enzalutamide, they were still followed up until they passed away. And what this showed is, I guess, what we would expect is that there was substantial crossover in the control arm. And what that means is patients who didn't get enzalutamide first, when they progressed, subsequently received enzalutamide or a similar drug such as abiraterone. So 76% of patients received enzalutamide or abiraterone after progression, after they became castration resistant. But what is particularly interesting is what the people in the enzalutamide arm got, because you really are at this point shoving all of your best agents up front, which sort of leads us to, to quote King George III from the musical Hamilton, what comes next? So Josh is laughing at me now. But you're not left with a whole heap after you've burned through a novel anti-androgen therapy. So the most common subsequent therapies in the enzalutamide arm: abiraterone. 26% of patients got abiraterone. 26% of patients got docetaxel, I guess either for the first or second time, and 21% of patients got cabazitaxel, a similar but different chemotherapy to docetaxel. 14% of patients got other chemotherapy, which in my experience would generally mean something like carboplatin, which is platinum-based chemotherapy, which is generally reserved for very late-stage disease, very heavily pretreated disease. And 4% of patients, or 3.4% I should say, got another emerging therapy that I'm sure we'll talk about at some point, which is lutetium PSMA, which is a radioactive biological agent that emits beta radiation after it's taken up by prostate cancer. It's pretty cool. The flip side of this, though, is that 39% of patients who progressed on enzalutamide had no further treatment. So almost 40% of patients, once they get through their initial treatment, whether it's a doublet or a triplet, have nothing else, which, is a bit scary, but I guess it's slightly offset by the fact that we still don't know what the median overall survival for patients taking enzalutamide is. In terms of other sort of data from this update, it was thought that the benefit was mostly seen in patients with low volume disease. So these are patients who wouldn't meet the charted criteria, who would have been in the control group. So patients who would have just been getting ADT and enzalutamide. Again, these are exploratory subgroup analysis, and as Professor Ian Davis would tell me, these are just sort of hypothesis generating. They're just illustrative, so take them with a grain of salt. But to illustrate the point that the subgroup analysis is trying to make, the hazard ratio for survival in patients with a low volume of disease who did receive docetaxel, a low volume of disease that didn't receive docetaxel, I should say, was 0.51, whereas the patients with a high volume of disease that didn't receive docetaxel is 0.69. If we take the patients with low volume of disease that for whatever reason did receive docetaxel, it might come back to what we were talking about before, Josh, patients with very concentrated sort of axial skeletal disease. The hazard ratio was 0.61, whereas the hazard ratio for patients who did receive docetaxel was 0.87. So that's a lot of numbers, but basically what it boils down to is the magnitude of benefit for sprinkling on a bit of enzalutamide on top of docetaxel appears at this stage to be less. And that's something to consider, especially if you've got a patient who has high volume disease. However, when we come to looking at these Kaplan-Meier curves, and this is something that any budding oncologist will become intimately acquainted with, the patients who received enzalutamide by itself in the lower risk patients, so patients with metachronous disease, so more indolent in theory disease, or patients with low volume synchronous metastatic disease, the curves between enzalutamide and docetaxel appear to overlap, which means the benefit may be equivalent, which means it's becoming much more of a trend that we're trying to avoid giving unnecessary treatment. And if we can avoid giving these people docetaxel and give them enzalutamide instead, then that is saving people obviously toxicity up front when they might not be getting much benefit. So that is the updated analysis of Enzamet, and it's a very interesting study. We know that Enzamet is active; it's an active drug, but what this study really looks at is finessing who we give it to and who we don't. And I guess my takeaways from this is that if you've got a patient in front of you that has lower risk disease, so metachronous metastatic disease or low volume disease, you might not shy away, that's the wrong word, but you might be able to spare them docetaxel and give them enzalutamide up front and help them that way. I guess that leaves the question, where does the triplet come in, where you're just hitting them with all three barrels? The standard answer to that, I guess, would be patients with very, very high volume disease who are very young and fit. And so you want to hit them hard and hit them fast and try and maximize the initial benefit, knowing that subsequent therapies will have, consecutively less benefit as the cancer gets more and more pre-treated, more and more resistant. So a couple of limitations, I guess. The docetaxel use was not randomized, so that does make it a bit hard to tease out how much of the benefit was docetaxel, how much of the benefit was the enzalutamide. But the signal and across the subgroups definitely suggests that there was a significant benefit. And again, the subset analysis, it is illustrative. It's not a hill to die on necessarily. You can't point to it and say, this is the reason that I have made this decision. But it is part of a growing body of evidence that moving these novel antiandrogens earlier is benefiting patients. And I guess the idea of sparing patients chemotherapy is obviously a very attractive one.
I get an interesting question. It's a bit beyond the scope, I guess, of the Enzamet trial. Like, if you're using enzalutamide earlier, has there been anything looking about re-challenging people with Enza down the track?
That is a question I'm not sure about. I know there is evidence that if you progress on one anti-androgen, re-challenging them with another one tends not
work.
Well, it does not work. Yeah, exactly. So, and I guess they all sort of, very simplistically, they all tend to work in a very similar way. So if a cancer has found a way to grow despite blocking that one way, then a similar drug with a different brand name or a different coating is not going to have too much of an effect. The difference, though, or where there is a little bit of subtlety, I guess, is those studies were done in the castration-resistant setting. So patients had, say, enzalutamide after they had become castration-resistant, and then they went on to abiraterone, where you're treating the same cancer effectively. I don't think it's very much of a stretch to say that hormone-sensitive prostate cancer and castration-resistant prostate cancer are two very different beasts. So I think the question remains unanswered, as far as I'm aware, about, re-challenging after the onset of castration resistance, whether you're going to still have an effect, and you might. I guess the question will be whether you re-challenge with enzalutamide or if you do abiraterone or darolutamide or something different.
Yeah, I was just curious because I was trying to figure out if there was any kind of pathway, because they're all good drugs, but it's just, it's a bit of a shame, because it's like a lot of the things that we treat now earlier on, Michael. It's that once they progress, you've kind of used that arrow in your quiver, which means potentially we need more drugs to kind of stem it. But again, maybe in something like enzalutamide, if you've got amazing overall survival and PFS, that if these are elderly patients, you might not need anything else because they essentially live out their days. They have a great life. You know, you treat them and then they don't need to see you anymore.
Exactly. And I think that, again, as I said at the start of this section, you know, this is sort of a fantasy land where we have access to anything and everything that we want because we can't use enzalutamide in this space. There have been grumblings, at least for the last few years, that enzalutamide might be getting approval for use in the hormone-sensitive space. But you know, in a perfect world where we had access to every drug that we could, I mean, you would be tempted to reuse something or reuse a similar drug that you know had worked in the past, especially if the patient was able to tolerate it. So that's where the finessing comes in, and as a more experienced listeners will know, you run out of evidence very quickly when patients get heavily pre-treated, and then you've just sort of got to take logical leaps, I guess, towards what you know or what you think will work.
One of the things I love, I think, sorry, Michael, this isn't really a question, but more an observation, going back to the people who author this trial. I work with one of them, and, you know, there's a number floating, I think, through Sydney and probably Melbourne as well, that are quite prominent prostate oncologists, and it's still very nice to see their names on such a, I guess, potentially game-changing trial, and also the irony that it's not approved in Australia.
Yes, exactly. I'm pretty sure this is actually something that is done not uncommonly in places like America. But yes, in Australia, by the nature of our public health system, we do lag behind a bit. So I guess coming back to our hypothetical patient, Josh, with what we now know through the course of this podcast is a patient who has high volume disease because of that spot in his humerus, and who is 68, otherwise well, and sits down and says, "Doc, what are you going to give me, or what do I need to do?" What are you going to give him? I guess take it first in the current setting, based on restrictions that we have, and then in this wondrous fantasy land we keep on talking about, where we can do anything we want.
Well, in the restricted world, I mean, if it's all about open disclosure, right? Because we have to have the discussion that we've got two pretty good treatment options. Sure, you know, enzalutamide looks amazing in this setting, but we don't have access to it. So if they're willing to self-fund it,
which I think is about 14 grand a year by my very bad calculations, looking at the government websites,
which is, you know,
that's
a lot of money, especially
that's even more lattes.
And if you're on it for 5 years, and let's say you're a retiree, or, you know, you just don't have the finances, that's just not feasible. So in the real world, we would have to go for the docetaxel. And then the good thing about that is if you go for the docetaxel and then they do progress, and then you're looking for options, they become castrate resistant, you have enzalutamide available, right? And it's still a very good drug in the metastatic setting. Sorry, in the castrate resistant setting. In an ideal world, and I have everything approved, and I can literally click a button and my patient gets it, you know what? I would probably think about, I'd have that discussion and see what they want, but going for enzalutamide is not a bad option. You know, if we give this person 5+ years, in 5 years' time, the landscape's going to change again. There's going to be more drug options, you know, more studies that have been published. And so ideally, there's probably going to be more options for this patient to take.
Would you give them the triplet?
I think that's a harder question to answer, because I don't think there's enough evidence to say the triplet therapy would be that much more beneficial than just the doublet. Would you agree, or would you disagree to that statement?
Yeah, no, and I guess the question then, you know, I do agree, because the evidence is look, it's there. There's a suggestion, but it's certainly not robust, I guess, and you need dedicated studies or dedicated data to actually answer that question. But I guess the question is, if we both agree that the triplet is an option in very select cadre of patients, but probably not our hypothetical patient. What doublet do you think you'd choose? Would you use the tried and true docetaxel, or would you use the new kid on the block enzalutamide in a patient with, let's make it difficult, with synchronous high volume disease, so higher risk of progression and aggression, and where Enzamet, I mean, the suggestion of a benefit was potentially smaller.
Oh, it's a hard one. It's a hard.
Yeah, it's not meant to be easy. It's not meant to be easy.
This is not fair. Look, I guess I would go whichever one. If they're a young patient, I would go whichever one has the best evidence, including the hypothetical benefit.
So you would use Enza?
I'd use Enza, right? Because these guys, let's push him 15 years younger. He's a 45-year-old guy, 3 kids, working full time. I want him to live as long as possible, so we have other options down the line. And at the moment, enzalutamide just kind of, it's promising. It shows something that I would probably offer up front, especially if it was available.
I guess if we are looking at the 45-year-old, that might be someone that we're more inclined to give the triplet as well.
Yeah.
If they can take it.
Would you agree with me, or would you disagree, Mikey?
Yeah, no, I would agree that, it always comes down to a balance of toxicity, patient preference, and what you think the benefit is going to be. I mean, it's always a guess. It's always an educated guess. I think in very young patients, sort of borrowing for what we're starting to do in colorectal cancer is pushing everything to the front. And
that showed a lot of benefit, right? That showed, pushing people really hard in metastatic colorectal cancer beyond the scope of today's discussion.
No, we'll get into that later.
We will. And if you're really interested, tell us and we will move it more forward. No, just kidding. Hitting people hard, there is a subset that we cure, right? Even in the metastatic colorectal setting. And, there's a lot we don't know, but what we know is that hitting people hard has generally shown better outcomes. Yeah. Treating people earlier has better outcomes. And this is a change in methodology from 20 years ago, where they like to reserve their good treatments because they know the person's going to progress. But we couldn't manage symptoms very well back then. We couldn't manage a lot of things. So that's kind of my theory. And Michael's completely correct about sort of stealing things from other cancers to use in their own stream.
All right, we might leave it there. Thank you very much for joining us. If you like this episode, please subscribe to wherever you get your podcasts, or from wherever you get your podcasts. Thanks very much, Josh, for that invigorating discussion on hormone-sensitive prostate cancer.
I love a bit of a debate, you know that.
Yeah, it's good for the soul. All right, well, until next time, then it's goodbye from me and it's goodbye from him, and take care, and we'll see you next time.